So, hi, thank you, listeners, for joining us today. We're here with Dr. Claudia Chisari. She has a PhD in Vulvodynia from King's College in London, which is the first UK PhD on this topic, an honorary research associate at King's College in London, a research advisor for the Vulval Pain Society, an internationally recognized expert in persistent pelvic pain. So, thank you, Claudia.
Thank you for having me.
If you want to tell us a little bit about yourself, I know I just gave a few highlights, but just a little bit about what brought you to this subject, and yeah, just what you're doing now.
Yeah. Well, first of all, thank you for inviting me. I guess this all really started from a place of personal experience and a deep sense of injustice. I had a pelvic surgery when I was 20, and not long after I started having vulvodynia. At the time, I was doing my master's in medical psychology. Basically, it's looking at the support you can give to someone with physical health problems, and you can also support them from a psychological point of view. So it's all about long term conditions. So I was already really interested in this field, but suddenly I was living with what I was studying. I see the irony in it now, but when I started looking for answers about vulvodynia from a research point of view, I found almost nothing. There was barely any research. I felt quite confused because I could see that like 1 in 6 women, 1 in 7 women had vulvodynia, but there wasn't, it was basically invisible from a research side. And so I decided to do my master's thesis in vulvodynia and then a PhD in vulvodynia. The reason was I wanted to shine a light on the condition that so many women experience, because it wasn't only under researched, it was basically invisible, and I wanted to change that.
So, what really inspired you to pursue the UK's first PhD focused specifically on vulvodynia? Was it like personal experience that you were going through, somebody else's experience that inspired you?
Yeah, my own personal experience. I did start having vulvodynia right after my pelvic surgery, so I was looking for answers because my doctor wasn't really helpful in giving me any answers to, causes and treatments. So naturally, as a young researcher, I went on Google Scholar, and I just wanted to find out what the research said, and there was nothing. And so I thought, okay, can I maybe try to change that? Can I try to do some research in this field and start that way? And I found it very empowering. I just didn't feel like I was, I guess, losing control and having no answers. And then it just became part of my life. And then that's what brought me to do the PhD. I guess from a PhD point of view, I wanted to do something quite pragmatic, quite, developing a treatment, developing an intervention, not just researching for the sake of research. And so that's how it was structured.
I do love stories where it's like our personal experience kind of leads us to our purpose, and and you're just bringing something. Definitely, this is something bringing a lot of impact to the world for women in the UK, everywhere. Is there, since like your beginning of this research, have you noticed that the research landscape for pelvic pain conditions overall has changed since you began your work? Like, do you feel like there's any progress? Obviously, there's a lot to go, but do you think that there's been any progress so far in terms of like awareness and just research overall?
Yeah, I mean, in the past 10, 15 years, I can say there's definitely more awareness now. We moved from what is vulvodynia to how do we treat it? What's the cause? What are the causes and everything? And that's a big step. But this funding landscape doesn't reflect the scale of the problem. We're talking about conditions on the whole that affect 1 in 3 women, pelvic pain as an umbrella term, women and people assigned female at birth. So yes, there is progress, but we need way more funding and research.
How do you know think like you said needing way more funding and research, which obviously is so needed all over the world for everything women's health. What do you think is like the driving force in getting that research, whether it's like on the policy side um, or from like the medical field or other universities that want to support? Like, where do you find the best way to get access to that funding or to raise awareness?
You mean to pursue that research in a university?
Like, who do you find is supporting it the most as it like right now?
In terms of institutions? Sorry, I'm not sure what you mean.
Yeah, in terms of like raising awareness, like who do you feel like is hearing you and responding positively to it? Is it patients? Is it people in the medical field? Is it in other institutions that want to like support the research?
Yeah. So, I mean, obviously, patients come are the first ones, right? I'm a patient, I want to say as well. Same, so I guess I can see it from both sides. Definitely patients. I mean, patients want to be heard. They want to be validated in their pain. So, of course, like they are the ones that are pushing and just like pushing for the changes in policy and funding, of course. Research institutions as well. I mean, I did my PhD at King's, right? And I was fortunate to do that, where the research was recognized and it was also encouraged in this field. So I can say from, in my own personal experience, I had a very positive journey doing academic research in Vulvodynia. But I think in general, when I was looking for funding, there weren't many scholarships. Like finding the funding, getting the funding wasn't really easy.
Yeah.
And so I think, again, things do need to shift a little bit more. So there's kind of a mismatch between patients and, I guess, the research that happens, where patients really push, but the research hasn't been translated enough, considering the demand that there is from patients.
Why do you think it's conditions like vulvodynia and endometriosis that have historically received less research attention? Is it, you think, just like lack of overall awareness, lack of education on for medical professionals when they're in med school?
So I think there's a few layers to this. One of them is, for example, vulvodynia. It's invisible pain, invisible to not to the patients, but invisible pain. And so it gets often, there's the whole gaslighting thing and invalidation and misogyny. And same with endometriosis, until there's evidence that's showing in tests, which is problematic in itself. Sometimes, well, oftentimes there's no attention, right? And we know obviously from pain science that pain is what the person says it is. It's not the scans, it's not, there's none of that. It's a subjective emotional and physical experience, right? But I think on a personal note, apart from the invisibility of it, there's something deeper. This is my own personal take on this, and I think part of the reason is that these conditions are not tied to fertility, pregnancy, or babies. I mean, of course, endometriosis has connections to infertility, but not primarily,
Yeah.
if that makes sense. There are, chronic pain conditions, and one of the repercussions is fertility. But this is an area of women's health, fertility, pregnancy, and babies that gets the most attention and funding. And something like vulvodynia, that it's about women's body, pain, and sexuality. These conditions in general are taboo topics still in medicine. And it reminds me a little bit of how menopause has been treated historically. So it's important, life changing, everyone goes through it, but it's sidelined because it doesn't fit into the reproductive health
Yeah.
narrative. And so we need to unlearn a lot of the cultural and systemic biases about these health experiences and conditions that are considered worthy of care or unworthy of care.
That's when you touched on menopause. That's something too that I've noticed in the past couple of years is getting more attention.
Yeah.
But then I think about it, I'm like, is that because I'm like in this women's health world? So like I'm seeing it, but it's really not. Or is it something that like somebody who's not in this world is going to get more attention to it as well? So I don't know. But overall, like what were some of the most surprising findings from your research so far?
Gosh, there's more than one. I would
That's like a lot of
say,
questions.
yeah. I guess one of the most important ones was realizing how deep the emotional and relational that there was in vulvodynia, and it's often just as significant as the physical pain, if not more. So women spoke about all these feelings of being gaslit, ashamed, and completely isolated for years. And that kind of distress doesn't just sit on top of the pain, it fuels it. It becomes part of a person's experience. And it's the same with all the other pain conditions. And of course, I knew this already as a patient, but seeing it reflected so clearly in so many others women's experiences was validating, but also sad. What struck me as well was how often vulvodynia is misunderstood as a sexual pain disorder. For many people, the biggest struggles are everyday things like walking, sitting, sleeping, being able to get dressed. So this condition affects much more than intimacy, but yet it's often all it's reduced to. And then, of course, body image, the overlap between pain, identity, and self image is so complex and important and is not explored enough in research and treatment. And so that's why I developed a digital treatment program during the PhD, something that was accessible for women, holistic, as in multidisciplinary and evidence based. And the results were encouraging. We've seen real reductions in pain intensity and interference through this digital support program. And that's what excites me the most, translating research into something that genuinely help people feel better.
Yeah. When you talk about the deep psychological aspect and the medical gaslighting, one of my, I don't want to say favorite things because it has like a positive connotation to it, but I do love asking other women with endometriosis or any pelvic pain conditions. It's usually endometriosis for me. What like the craziest thing a doctor's ever said to them is, and it's unbelievable, like how many women are asked about their sexuality, like when they start talking about intimacy and how that's painful. If they're, heterosexual, and then their gynecologist would be like, well, are you sure maybe you should think about your sexuality. Maybe you're just not attracted to the men that you're trying to be intimate with. It's like, how can you question that to a patient? And like, that's another personal level. And it's ridiculous. Like how, instead of just, at least for endometriosis, like the gynecologist should just be referring somebody with that type of pain, say you might have endometriosis, and refer them to endometriosis specialist. But instead they're medically gaslighting, and saying outlandish comments like that are such a personal level, and just that's the last thing you want to be questioned about when you're in your gynecological office and complaining about pain. Um,
100%.
but nonetheless, we're talking about vulvodynia a lot. So if we could just kind of demystify a little bit, for listeners who are unfamiliar, could you explain what vulvodynia is? And you've already kind of touched on how it affects patients' daily lives, but just a little bit more about the disease overall or the condition overall.
Yeah. So vulvodynia is defined as chronic, so long term, like 3 or 6 months, vulvar pain. So the external genitalia of a female at birth. Um, it can be anywhere in the vulva, could be the entrance, could be clitoral pain. And it's, one of the main symptoms is like burning pain. It can be also described as stinging pain or rawness. And the defining feature, I guess, about vulvodynia is that there's no obvious cause, as in it's not caused by an infection or something like that. It's called idiopathic pain. That doesn't mean it's not real. It's just that there's no obvious cause in the way that it's currently defined.
Okay.
Some people can feel like sitting on a glass or being sunburned. Um, and it affects, I mean, it ranges. Everyone has a different experience with vulvodynia, but it can go from some discomfort during sex, particularly with penetrative sex, to inability to sleep, sitting, walking, and wearing any type of clothes. And because it's invisible, often women suffer in silence.
So with endometriosis, most women are misdiagnosed with pelvic inflammatory disease,
Ah.
amongst other things, but that's like the most common. So what are the most common conditions that women could be diagnosed with, or misdiagnosed with, if they actually have or could actually have vulvodynia?
So the main condition is it's all in your head, which is not a condition, but that's one. But oftentimes, jokes aside, it could be an STI. Often, there's often a thing. I mean, I was on the receiving end of this, by the way. Just personal note, like when I didn't have vulvodynia for a few years, and then I started having it again. And I was doing my PhD in vulvodynia. This is the irony of it. And I went to the doctor and I said, "Look, I've had vulvodynia before. Is this vulvodynia? Because I know that there's a history of misdiagnosing vulvodynia for an STI or thrush." And he said, "No, no, no, you have an infection." By the way, I did not have an infection. So it's happened to me again and again, even with, I guess, with some of the PhD knowledge. And even if you say it, it can happen. Both of these, it being in your head or an STI or thrush, instead of actually finding out what you have, which is vulvodynia, oftentimes is false and damaging for patients. Um, and I think it's because some healthcare professionals lack that training and there's confusion, and that leads to misdiagnosis or dismissal.
I'm sure if you and I both had $1 for every time we were told it's just in our heads, we would never have to work again.
Yeah, definitely.
What are like some of the most common misconceptions about vulvodynia that you encounter from both patients and other healthcare providers?
Hmm. So common misconceptions are that it's in your head, that it's, you need some psychological therapy and it will cure it.
Yeah,
Mm, everything looks normal. I don't even know what that means. Like, it doesn't mean anything. If you have pain,
scan.
you have pain. And I mean, these are the common misconceptions. Some trauma, like childhood trauma, I think is thrown in a lot. It's one of those things that's, I find it a bit lazy, right? Because you can't really, it doesn't really mean, like saying stress, like stress, okay, whatever, right? It's not, it's just an easy thing to throw when you don't know what to say. So a lot of the time, that's what people hear.
I love when doctors ask, "What's your stress level on a scale of 1 to 10?" Like, how do you?
Well, now 20 that you asked me this question.
Like, doesn't everybody say 20? Like, um, I hate when they ask those questions. Um, so overall, like, obviously it's very, very, very hard to diagnose and goes misdiagnosed for years, being invisible. But other than the fact that it's invisible, why else do you think goes undiagnosed for so years? Like, more the fact that it doesn't show up on a scan, more the fact that medical gaslighting is just so heavy, combination of things.
Mhm. I think a combination of things. Again, the vulva looks fine if you have vulvodynia, unless you have something else in addition to the vulvodynia. So there's that issue. There's no scan that really, the way you diagnose vulvodynia is through a cotton swab. You just put a bit of pressure in the vestibule, so the entrance of the vagina here. And then if you have pain, that's vulvodynia. So, there's no scan yet. I like to say yet because also we don't see it yet, but something
Yeah.
obviously isn't working. Otherwise, you wouldn't feel pain. So, there will be a point, some point, maybe not in our lifetime, where, we will see what's going on. Um, and I do think lack of medical training, definitely. I mean, vulvodynia, the first definition of vulvodynia that was like backed by quite a lot of by consensus among healthcare professionals was achieved only in 2005. So that's quite recent. Mm.
So I know before this you had noted that studies suggest around 8 to 16% of women will experience vulvodynia at some point. So that's a lot of women. Are there any specific risk factors that these women can have, like whether it's hormones or any other things?
Yeah, I mean, I like to say that vulvodynia is a bit like a syndrome. Like there's a few causes. It's often more than one. We don't really know what causes vulvodynia yet. But there's been a few, some research suggests genetics, and the guidelines suggest a mixture of, again, genetics, hormonal factors, musculoskeletal factors, um, and no stress. Not stress, but all these factors, neurological factors that can affect basically whether you're more likely to develop vulvodynia or not.
So endometriosis overall has so many comorbidities. Would you consider vulvodynia to be one of them? Like, is there any correlation between endometriosis and vulvodynia, or would you say it's more other types of pelvic pain conditions that align with endometriosis?
No, 100% vulvodynia is very common if you have endometriosis, vaginismus as well. There's that pain, that you have that abdominal pain and pelvic pain. And, vulvodynia, we know, has also a musculoskeletal component where your pelvic floor are not functioning as they should, because when you have pain, you tense up or you're weak, or basically you're not using your muscles efficiently. And so, if you have pain like endometriosis, you're more likely to have other pain conditions, oftentimes vulvodynia, bladder pain. We see quite a bit in endometriosis, fatigue, and allergies. There's more evidence also that endometriosis is related to, you're more likely to have other autoimmune diseases. So it's not just about the uterus or ovaries. This is a whole pain processing system that is not working as it should, and it's a whole body disease. It's not a gynecological disease. Our understanding of endometriosis has changed fundamentally. And so, yes, you're more likely to have other pelvic pain conditions, but also other autoimmune conditions on the whole.
I'm so happy that you touched on the inflammation or the immune system aspect of all this. What do you feel is the role between inflammation and the immune system in endometriosis, vulvodynia, all these pelvic pain conditions?
There is some research in vulvodynia around inflammation. We don't really have enough evidence in vulvodynia to suggest that this is an inflammatory condition. That doesn't mean it's not that. It's just that we don't have the evidence, right? So I wouldn't be able to say too much in terms of the vulvodynia research. It's so there's really barely any research, unfortunately. But in endometriosis, of course, there is a link between inflammation and immune dysregulation. That's why we see, again, links with pain and autoimmune diseases or allergies, because it's a systemic issue. It's just not local pain. So with endo, we have more of that research. With vulvodynia, we're not there. And it could be that that's not what's going on. But again, there's no research to suggest either way. For now, we have to say that it's idiopathic pain. We don't know why the pain is there.
Do hormones influence pelvic pain conditions like vulvodynia? I know they impact endometriosis. Because the other thing with that is like, in terms of treatment approaches with endometriosis, I mean, gynecologists give out, and to what you said before, it's a whole body disease, not a gynecological one. But gynecologists give out birth control like candy, and it just can act as a band-aid and kind of mask symptoms while the endo's growing, or post-surgery. I mean, I went on birth control for a little bit to help kind of manage like my high estrogen and get that leveled out. Like, so it's a treatment option, or use treatment loosely. But how else do hormones impact different pelvic pain conditions like vulvodynia?
So starting with vulvodynia, I guess we know that hormones affect nerve sensitivity and tissue response, and we know that some people find pain worse at certain times of the month. It's not for everyone has a different experience, but that can happen. In terms of hormones, like for some people, for example, hormonal factors are important in vulvodynia. Estrogen, changes in estrogen levels can affect pain in the vulva, and that's why estrogen creams can help for some people. That's not everyone, some people.
Yeah.
And of course, why sometimes vulvar pain gets worse during menopause, and it happens, vulvodynia can develop around the time of menopause. So there is certainly, for some people, a hormonal sort of involvement. It's also important to note that the pill, this is anecdotal, again, because we don't have research, but for some people on the pill, they're more likely to report vulvodynia. We don't exactly know why, because we don't have research. But there is definitely, anecdotally, I've seen a link between being on the pill and having vulvar pain. And with regards to endo, yeah, again, it's a bit more clear, I would say, with endometriosis, because we know that hormones can affect inflammation a lot more clearly. But we need more research to establish whether there's a causality here or not.
Out of the current research, and like the research that you've been working on, what treatment approaches have shown the most promising? Or is there an answer to that?
In pelvic pain, I would say generally the most effective treatments are multidisciplinary treatments. So, not, not any, basically things work together. There's nothing that works on its own, because pain is social, is psychological and physical, right? So, particularly with vulvodynia, a combination of pelvic floor physiotherapy, psychological support, and sometimes medications, when combined, they always work better than anything on its own, right? I mean, we're humans in an environment, we're never on our own, and pain is the same, right? And with vulvodynia, it's not a quick fix condition. It needs the care it needs care that addresses body and mind. But if we're being honest, because we don't have research, there is actually a recent scoping review that was done on a type of vulvodynia called provoked vestibulodynia. So it's provoked pain in the vestibule at the entrance of the vagina. It highlighted that there's no strong evidence for any one treatment that works, because the trials weren't comparable. Basically, they just measured different things, so you couldn't see what was working and what wasn't when comparing them together. But that pelvic floor physio was the only approach that had some limited emerging evidence. So I guess my message would be, if a healthcare professional is pushing for a specific solution and just saying like this is definitely going to work, and then the patient doesn't feel any relief, the research isn't there yet. So it's okay to ask for something else. And we're
Yeah.
still at the stage of trial and error. But psychology and physio, I would say, are likely to have a positive effect when combined together in a condition like vulvodynia or other forms of pelvic pain.
What role does pelvic floor physiotherapy play in managing these conditions? Because I know for endometriosis, it's super helpful.
Yeah.
But overall, for all pelvic pain conditions, um, what like exact role does it play in management of the pain?
A huge one, because when you have pelvic pain, your pelvic floor doesn't quite behave. It can be tense. It might not coordinate as well. It could be weak. It could be a combination of things. And so physio can really help you train the muscles to function properly. It's transformative for many women, and with touch sensitivity and specific pelvic floor exercises, like for example the perineal massage, where you're touching the perineum or you're touching the vulva, even that sensory experience of being in touch with your body can really help bring that level of pain down, because you're getting reacquainted with your body. And I think in itself that can be therapeutic.
Are there any emerging treatments or research directions that you're really excited about and have a lot of hope for in the future
I
for pelvic
think,
pain conditions, endo, vulvodynia?
yeah, I mean, it's hard because they're very different conditions. So,
Yeah.
but I would say, digital therapeutics are very promising. They can really help you, remotely. And I know, not everyone has access to, a medical care team. Actually, very few, a medical care team that is multidisciplinary and specialized in pelvic pain and la 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 la. So I think, there is a role for remote care, to make this support more accessible and also less expensive, because it's incredibly expensive for women to have to go to different healthcare professionals for different problems. And for endo in particular, some researchers are developing at home diagnostic tools. And I think that's very, very exciting.
Yeah, I've been saying a lot about that lately. Definitely hope that
Yeah.
turns into something.
Yes.
The fact that surgery is the only way to diagnose it is crazy.
Yes.
Or to officially diagnose it.
Yeah.
Um, what we touched on a lot today is the patient, and how important it is for the patient to be knowledgeable on these things because of all the medical gaslighting, and how especially like the financial responsibility falls on the patient. What advice would you give to someone who isn't being taken seriously and struggling with pelvic persistent pelvic pain?
First, you're not imagining it, and you do deserve care. Document your symptoms, bring someone to appointments, which I know it shouldn't happen, but if it gives you peace of mind and some extra level of like support,
Yeah.
then just do it. And if a provider isn't listening, it's okay to change, and you're allowed to advocate for yourself.
As a patient and medical professional, what self management tools have you found personally or through some patients that they have found or you have found the most helpful for daily pain management when you're in the process of going to these doctors and trying to seek an answer and a diagnosis?
Um, there's a few. I would say gentle movement to learn how to calm the nervous system down a little bit. Acceptance and commitment therapy, or called ACT, is a powerful tool that I use with clients. It's nothing to do with removing pain. We can't, psychology can't fix that, but it can help you. It can help with the relationship you have to pain and improve quality of life, which is incredible. And then community, that's so important in these conditions because of the isolation and stigma. Knowing you're not alone, I think, is a form of medicine in itself.
I mean, being post operative and finding like personally like that whole endometriosis community, that has been so I can't imagine how different the experience, especially leading up to a diagnosis, would have been in dealing with the pain if I had that community prior. Like it is
Yeah.
super, super impactful. Even just being able to like to vent to people who get it, that is like
Oh, it's,
alone
it's
its
huge.
own little healing journey. Um, But overall, like, how do you recommend partners and family can best support someone if they don't have that community of other patients?
Listening without judgment is so important, without trying to fix it. Just validate. I know there is a and it often comes from a good place, right? They just try to, oh, have you tried this diet, have you tried that. Like, if you've had pelvic pain and you're listening, you know that you've tried pretty much everything, and when I see women, like, through the clinical practice, like, I don't think I've seen a woman that is just hasn't tried 3 4 things already, right? So we're all very well informed. We all have to, unfortunately, we shoulder that weight, because if people aren't fixing it, some doctors aren't fixing it, then we try to do it ourselves. So
Yeah.
having an opinion like that, although it comes from a good place, in terms of like diets or whatever, doesn't always help. So
Yeah.
the second thing would be patient, ask how you can help, and to educate yourself on the condition. And I think love and empathy can really make a huge difference in someone's healing journey and managing pelvic pain.
It's so hard to not get, like you said, the people mean well, usually, but
Yeah.
it's so hard to not get frustrated when people are like, when you have
Yeah.
like something going on inside you and you're like, have you tried keto? And they're like, then they always have like a tidbit story of like somebody who, personally, it was somebody in my life who, their partner was struggling with PCOS symptoms and then started eating keto for like a year and her symptoms improved. And then like, I really think if you started a keto diet, your endometriosis would go away. I'm like,
Yeah.
well, it's not how it works, but I appreciate
The
we're talking about
sentiments.
two different conditions here. And I'm sure it could, obviously diet helps with symptom management, inflammation, things like that. But yeah, definitely trying to get rid of that idea that these diets can make the disease totally go away. Yeah, it's
Yeah.
hard to like not get frustrated with people given that type of information.
Yeah.
Um,
And now that you mention this, in endometriosis, there is a case for diet, right, with
yeah,
inflammation. In vulvodynia, there is not. And I see a lot of women that do like an antihistamine diet. And I understand, because food is something you can control, right? And
yes,
it's something you want to try, but there actually is no evidence that food affects vulvodynia. It can affect, bladder health in some ways, like if you have a lot of caffeine and you're struggling with that, sure,
yes,
reducing caffeine, but like acidic food and all of that, there's no evidence. And I think a lot of women, then they just follow a very strict diet on top of the pain, and it becomes unmanageable.
yeah.
And yeah, if you're listening, just don't, it's not worth it.
Especially, I'm so happy you touched on that because especially if you have other issues like gastro issues and you're already so limited in your diet, to then
Exactly.
start some type of super strict diet you're already restricted and then you're just restricting yourself more and then it's hard to eat and
Yeah.
become such an issue in itself. How do these conditions impact? I mean, we know how these conditions impact intimate relationships, but what type of resources are available to help navigate these challenges in terms of like like sexual relationships and how to manage that when you are dealing with this type of pain all the time? Like,
It's tough and it can be difficult. It often is, but it's not impossible. We know that pain affects desire, self image, and connection, and vice versa. And for many people, intimacy becomes a source of anxiety and shame, instead of closeness. Even watching, like a sex scene becomes on your TV, you just detach from it. You just don't want to deal with it. And I'm sure that so many people have similar experiences like that. But something I see often in my line of work is that women push through pain, especially when it comes to penetrative sex, because they feel that's what it's expected or what counts as real sex. And oftentimes their partner, particularly if they're in a heterosexual relationship, might push for it. It's so important to say this clearly. Sex isn't penetration, and penetration isn't only the only type of sex. There's so many ways to experience intimacy and pleasure. And sometimes the first step is to actually unlearn these narrow scripts that we've been taught about what sex should look like. And for women, whether they have pelvic pain or not, this has nothing to do with pelvic pain. Penetration isn't the most pleasurable act. We know from general research on sex, that penetration is the least preferable sexual act. So there's something there. But again, with the right support, like a psychosexual therapy or communication tools, many couples find new ways to be close emotionally and physically, particularly when they unlearn some of these scripts.
I'm so happy you said about unlearning some of the scripts, because I mean I didn't even know that either. So that it's like penetration is research to not be the number one. So that's, yeah, definitely something that people should bring up in their relationship, is like the science behind it, to kind of support how they're feeling. But then, I mean, that alone, this is how you're feeling, should be valid enough. But like you said, some partners want to keep pushing, and if they have a better understanding of like the reasons why and some of the science behind it, then maybe they'll be more apt to the emotional conversation as well, and navigating the situation. Oh, are there any current, I mean, obviously you're working on things now. What current research projects are you working on that listeners should keep an eye out for, that you want to talk about or discuss?
So I guess the main one, and it's been cooking for a bit. It's a digital health app. It's called Bloom Health. The app offers expert-led care for women who have pelvic pain. It's basically your first pelvic pain companion. It combines psychological therapy, pelvic floor physio, and sex and relationship therapy for pelvic pain with different programs, whether you have endometriosis, vulvodynia, vaginismus, all in one place. Because I was tired of going from the psychologist to that for that, and then the physio for that, and if you find them. And so this is an end-to-end care tool, where we want to make this support accessible to more people. And anyways, it's launching on the App Store and the Google Play Store, in June 2025, and it's available worldwide. So you can already join our waitlist now, and we'll let you know once it's ready. But also, I'm continuing to supervise and do research in pelvic pain at King's.
That opposite, like you said, having everything in one place and not having to go here for this and here for that. Talking about stress earlier, like that, that eliminates so much stress of going from this person to this person just to be sent back to the other person. So that's awesome. Thank you for developing that. It's a great idea. Is there, as we're closing this out, if you had one piece of anything that you would wish any healthcare provider would understand about pelvic pain, what would it be? Especially since you have that insight being on both sides.
Hmm. That I guess for sure, pain is real. Your patient is the expert in their own body. As I said, particularly, I mean, that's the case across the board, but I think in particular with pelvic pain, we become experts. We look at research, we look at what could work, we do so many experiments. We know our stuff. So the important thing is to listen with empathy and not ego. And if you don't have all the answers, that's absolutely fine. That's how, when you signpost to another professional, and the way you respond makes all the difference. And I'm sure, Nicole, I mean, if you have I'm sure you've come across like healthcare professionals who may have not been specialized in endo, but at least if they say to you that they don't know and they are receptive and they don't invalidate your pain, that's fine.
Yeah.
And that's human. So I think that would be my message.
Well, all your insights today have been completely invaluable. So thank you for teaching everybody about these pelvic pain conditions, highlighting vulvodynia. Definitely need more light on that. Like you said, incredibly under researched. So for our listeners who want to learn more about Dr. Chisari's work, we're seeking support for pelvic pain conditions. Highly recommend visiting Bloom Health. His website, it's www.bloomhealth.com. That's Bloom, Bloume. Bloom Health's at the forefront of providing specialized care and resources for those experiencing pelvic pain conditions. So definitely check it out, and follow Dr. Chisari on social media as well, where she keeps everybody updated on the research that she's doing. So thank you for joining us today. Yeah.
Thanks so much.